Hirschsprung disease or congenital megacolon is the absence of ganglionic cells, that's orbax plexus and Meissner's plexus in the anorectum. And the absence of ganglionic cells may extend proximally to involve colon also. This causes distended proximal colon causing congenital megacolon, that is megacolon. The etiology of this condition, it's associated with genetic mutations in chromosome 10 and 13. It is congenital condition and it is familial. 10% of patients with Hirschsprung disease has Down syndrome. Coming to pathophysiology of this condition, it always involves anus, rectum, and internal sphincter. It's involved in all patients where there is absence of inhibitory ganglionic cells. 80% of patients, we can also see sigmoidal involvement, that is rectosigmoidal area is involved. Since there is loss of inhibitory ganglionic cells, there is constriction of involved terminal part, terminally constricted segment, followed by transitional zone where only few ganglionic cells are present, so the transitional zone will be cone shaped. Then the proximal normal intestine will be distended due to obstruction at the level of the diseased segment. So this is about pathophysiology. Then we have various types of Hirschsprung disease. It is called as ultra short segment Hirschsprung disease if only anal canal with only terminal part of rectum is involved. It's called as short segment Hirschsprung disease is anal canal along with entire rectum is involved. It is called as long segment Hirschsprung disease if the along with anal canal and entire rectum a part of colon is involved. It is called as total colonic Hirschsprung disease if along with anal canal and rectum entire colon is involved. Then we have clinical manifestation. It's more common in males compared to that of females, and it's seen in 1 to 4,000 to 5,000 live births. 90% of patients have acute neonatal intestinal obstruction where they will have failure to pass meconium. By introducing finger into the rectum, it causes the passage of toothpaste like stool. Following 12 to 24 hours following intestinal obstruction, that's after birth, the patient will have features of intestinal obstruction like distension, and if they have associated enterocolitis, they can have features of perforation and septicemia. This is the manifestation, usual manifestation in 90% of patients, and in rectal examination, they will have tight sphincter. Already told, there is loss of inhibitory ganglionic cells, so there will be increased tone of muscles. So the distal involved part is narrowed and constricted. So we'll see tight sphincter because of involvement of internal anal sphincter, and also the rectum will be empty. In 10% of patients, they present with constipation, chronic constipation. The onset is within few weeks after birth. They will pass goat pellet-like stools and they'll have abdominal distension. This is about the clinical manifestation seen in Hirschsprung disease. On investigation, we do full thickness rectal biopsy under general anesthesia, where we will see absence of ganglionic cells and hypertrophic nerve fibers in nerve plexus in the involved part. On barium edema, where 3.6% barium solution is given, we see narrowed involved part and cone-shaped transitional zone followed by distended proximal segment of colon. The treatment of this condition, initially, we perform right transverse loop colostomy so that the normal bowel function is achieved. The contents of the intestine is brought out through colostomy stump. After the baby gains 10 kg of weight, which occur, and at the age of 3 to 6 months, we perform definitive surgery. Definitive surgery is modified Duhamel operation, where we resect the upper part of rectum. The upper part of involved rectum is resected, followed by anastomosis of the colon with the posterior part of rectum and anal canal. So we are resecting upper part of rectum and anastomosing the colon with the posterior part of lower rectum and anal canal. The lower extent of anastomosis extends till dentate line of anal canal. This is modified Duhamel operation. Then we have Sauer's mucosectomy and pull-through operation. as an alternative procedure to modified Duhamel operation. To summarize, Hirschsprung disease or congenital megacolon is characterized by absence of ganglionic cells in Orbeck and Meissner's plexus in anorectum, which can involve proximal colon also. Etiology, we have mutations in chromosome 10 and 13, and 10% of patients have Down syndrome. Pathophysiology, there is absence of inhibitory ganglionic cells in all cases in internal sphincter, anus, and rectum. 80% involves rectosigmoid, and the terminal part is narrowed. The transitional zone is cone-shaped, proximal part is distended. Types, we have ultra short segment type, long segment type, short segment type, and total colonic type. Clinical manifestation, 90% present with acute neonatal intestinal obstruction, where they have failure to pass meconium. 10% present with chronic constipation with passage of both pellet-like stools and abdominal distension. On rectal examination, they'll have tight sphincter and the rectum will be empty. Investigation, we perform full thickness rectal biopsy where we'll see absence of ganglionic cells with hypertrophic nerve fibers in nerve plexus. With barium enema, we'll see the narrowed involved part, transitional zone cone-shaped, and distended proximal part. Treatment, initially we perform right transverse loop colostomy followed by definitive surgery at 3 to 6 months of age. When the patient achieves 10 kg weight, we perform modified Duhamel operation or Suave's mucosectomy and pull-through operation or Swenson's operation. This is all about Hirschsprung disease. Thank you for listening.